why can't we find out complete healing within 6 months? If you extract the tooth, that socket will heal within 3 months to 6 months. In fact, they will place an implant in that socket within that length of time. In other words, there is something that remains that makes that healing a little slower. And we need to speed this up. This is what we...
And also, what do you think is the most overrated or overhyped topic of research within endodontics? And that's a more important question.
Without
creating a little bit of controversy here, huh?
We got another reality here.
So, Dr. Fouad, thanks. Who are you going to throw under the bus, Dr. Fouad?
There are several studies now that have shown that even among the patients that you consider healthy, if you look at genetic variations among them, there are some gene polymorphism traits, particularly for some of the cytokines like IL-1 beta, that are associated with persistent disease compared to other patients.
He looks at it and he throws it across the table and he goes, what the hell do we need a microscope to do apical surgery? He said, listen, here's the point. He said, how about the cost of care?
We have to play the game. There's no other choice. We need a good x-ray.
Wait a second, Dr. Nasseh. What did you say about a radiographic look? you do live in
That's
Boston.
true. We live in Boston, so that is heresy, Annie.
The home of the look.
Relatively novel technology that takes a tiny little sample of blood and it analyzes it for a large number of proteins. And the intent was to figure out the one or several proteins that will predict that the pulp will die anyway, regardless of what we do.
You didn't get this idea from Theranos, did you? I'm just kidding.
Well, everybody's ready to go. Yeah. Welcome to the Pulp Podcast, where we talk about all things dentistry and non-dentistry from a generational perspective. I'm joined today with my co-hosts, Dr. Koch, who's joining us remotely, and Dr. Parsa Shahidi here in studio. Parsa, exciting news. It seems like we're doing pretty well on the podcast front.
Yeah, I'm really happy, especially with our guest today, that we are officially the #1 endodontic podcast out there. So round of applause to you both.
That's
Congratulations.
To you, Parsa. That's great.
We're really excited about that. And it's very fitting, actually, believe it or not, because when we were talking about who we want to have to sort of celebrate this milestone, both of you, Dr. Nasseh and Dr. Koch, you immediately said the name of the person we're interviewing today. So it's a really, really big pleasure. Of course, many people, if not everybody, knows Dr. Ashraf Fouad, who's here with us today. But for those of you who want more context, Dr. Fouad is, of course, one of the most reputable names in endodontics. He's the professor and chair of the Department of Endodontics at the University of Alabama at Birmingham, as well as interim director of health information and business systems. Dr. Fouad has published over 115 peer-reviewed manuscripts, 62 editorials and invited manuscripts, 25 textbook chapters, and over 150 abstracts. He edited and co-authored several editions of the textbooks Endodontic Microbiology and Endodontics. He served as associate director of the Journal of Endodontics for many years, is currently associate editor of the Dental Traumatology and the Endodontics section of Frontiers for Dental Medicine. He's a diplomat and the past president of the American Board of Endodontics and has received the Distinguished Scientist Award from the Pulp Biology and Regeneration Group at the IADR in 2017 and the AAE President's Award in 2022, as well as, last but not least, the International Grossman's Award in 2023, and many other awards we just couldn't fit here in the intro. So it's a huge pleasure to welcome Dr. Fouad.
Absolutely. When I asked Dr. Fouad for his CV so we could do a little intro, when he sent me the document, I realized it was 75 pages. I didn't know I was in to read a whole book on a CV. So he's done great accomplishment, which is part of the reason why he's here, because we really want to get deep into the endodontic field and some of the science behind it and some of the misconceptions and things like that, which is why I'm going to have Annie go ahead and kind of get the conversation started.
I think the one question that's pretty generic and that we've discussed among the three of us is, from your perspective, Ashraf, what do you see are the major challenges facing our field? Is it education? Is it technology? Is it dissemination to the public of what root canal therapy can do?
So first, I want to thank you all for this kind introduction, and I'm honored and really delighted to be here on this very successful podcast this evening. So there are many challenges that face our field and that faces our association and how it promotes and promotes endodontics among endodontists, dentists, health providers, and of course patients. I think one of the most important issues facing us is how we define our outcomes. So the AAE has been for a number of years now interested in looking at this and specific questions as to what are the outcomes that matter. So the core outcome set has been an endeavor, and they formed a committee that I'm privileged to chair that has issued some requests for applications, and people have been funded at the University of Toronto, and several publications try to define the outcomes. Now we're at the stage of defining how to measure those outcomes. So when you talk about radiographic healing, for instance, are you looking at CBCT or periapical radiographs? And if you are looking at a CBCT, what would be an appropriate outcome? How long should you evaluate this case? How do you define pain? Is it the pain scale that we all ask our patients, or there's defined measures, particularly when it comes to persistent pain? How do we establish standards for root canal disinfection? So, interestingly, there are standards in dentistry for almost everything that we do: materials, sealers, gutta percha, instruments. There are no standards for root canal disinfection or technologies used for root canal disinfection. So I currently chair the Council on Scientific Affairs at the ADA, and part of my responsibility is to attend the standards meeting. And I've introduced a new work item to the standards program about root canal disinfection. We need to define what are appropriate standards for root canal disinfection. One of our challenges also is to get patients to accept retreatments and surgeries. We have a problem in educational programs in getting enough retreatments and surgeries completed by residents, and therefore many of our graduates and endodontists do not do those procedures in their practice, which leads to a lot of teeth being extracted. And of course, we need to inform the general dentists about how important these are as measures of saving teeth. And we were just talking about guided surgery, which is expanding and moving into the realm of dynamic navigation and so on. That allows us to do difficult procedures that were once more challenging to do with relative ease. I think that another thing that we have not really been recognizing enough, and we need to understand better, is how the host and the microbiome, both of those factors, can influence our outcomes in a significant way. We have not been really very cognizant of that or very aware of that because our electronic record systems are separate from the medical electronic record systems. So even most of the literature out there are from studies that ask the patient, what is your medical history? And of course, the patient may or may not share or the medical history, and they may or may not understand it fully. So the amount that they share is small, and they're also, in addition to diseases, conditions, and so on, there are the medications they're taking. There's also host-derived factors such as gene polymorphism and epigenetic factors that they themselves don't know about. And so the extent to which we combine our electronic health record with medical records will allow us to understand that the same treatment may be more effective for some patients, and for some others, we may need to be a little bit more aggressive and do additional procedures. So those, I think, are some of the challenges that we need to address in the next few years, decades or so.
Understanding that's coming from more of the academic research aspect. In terms of more of an overview of who's doing the endodontic procedures in North America, what are the challenges that you see going forward in terms of, and this is just my opinion, I think where the big problem is in endodontics is not in the postdoctoral program. I think all the postdoctoral programs are quite terrific. It's the undergraduate level. There is an enormous discrepancy on the undergraduate level. How can we address some of the concerns that both you and myself, we both share?
Excellent question. So our pre-doctoral students are doing fewer and fewer cases of endodontics in dental school. And that's because the curriculum in dental schools is exploding, and they are under tremendous stress to do all these other things and to go out on rotations in the community and serve the community and so on, because that's a mandate that dental schools generally have. At the same time, they graduate and they work in DSOs and other types of structures that expect them to do a lot of endodontics because that is a very profitable procedure. And they find themselves treating cases that they're not really very well trained for and have not really done before. The other thing that is happening is, there is a thought or a myth that, technology can help you do difficult cases. But if you have not been trained to use a particular technology for a while, or if you go to very brief vendor-sponsored courses, you may get into a procedure that results in using technology inappropriately or inadequately. And so we find ourselves in this dilemma that the Commission on Dental Accreditation requires us to certify that every student is competent in treating an endodontic patient or managing pulpoperiapical disease. And we find ourselves in the difficulty of defining what that means. Right. What does it mean to be competent? Because, of course, there is a wide spectrum of cases and case difficulties that involves. So I think the AAE tried to simplify the process through the case assessment form that they developed, trying to define what would be appropriate. But at the same time, I think CODA needs to understand that the world has changed and that we have a very big gap that keeps getting bigger between the specialist training and the general dentist coming straight out of school. In that perspective, we continue to struggle. So I agree with you that it is a problem. I don't have a solution for it. We're trying to understand why that is, that we just have less time and so on for them to do cases. We have fewer referrals for predoctoral students from the outside, mostly because dentists in the community are just doing their own.
I'll conclude with one thing that Ali has continually quoted me on, and that is you can't worship at the altar of technology.
That's right.
All right. That's it.
That's so true. And I think, some of the solutions that we need to find, as you said, is in much simpler ways rather than technologies. First and foremost is having a better understanding of the disease model. And I think what you mentioned about this lack of clarity, I think that's a stark problem that we face because historically we've trained Parsa and undergraduate students and everyone to kind of judge success based on a radiographic appearance. But, the radiographic, that lack of calcium presence at the apex of the tooth is merely a radiographic proxy that we use to infer potential, persistence of infection. And in many ways, the fact that we've taken the patient entirely out of this equation by not even asking them how they're feeling and measuring success and failure purely based on the radiographic appearance is what the issue has been. And I think your article on diabetes and how it does help, it causes this issue in terms of delayed healing, which creates this confusion whether the cases have healed or not healed comes really to mind. But my question to you is that, so do you feel satisfied with the current disease model that we have for endodontics? And if you could, in a very brief way, explain it for our audience, because we have a lot of pre-docs as well as residents that are watching, and I think having a good understanding of the disease model and then the proxy we use for measuring it and so on could be a little bit helpful.
Very well. So throughout my career, I have been very interested in how apical periodontitis develops and how we can treat it more effectively. So I started my career looking at animal models, and I've induced apical periodontitis in many, many animals, both rodents and ferrets, and studied it histologically, radiographically, and immunohistochemically, and so on, to find out what's going on. So fundamentally, we're dealing with a microbial disease that results from pulp necrosis. The pulp is one of the tissues that die at the highest rate in the human body. I don't know other tissues that die as frequently as the pulp, primarily because of poor vascularity in response to the irritants. Interestingly, that very point of how the pulp dies is the subject of elegant work out of the University of Pittsburgh. Dr. Ariadna Letra and her group looking at genetic variation among people who have deep carious lesions but have a vital pulp response within normal limits, and other patients with deep carious lesions that have pulp necrosis, apical peritonitis. Why does the pulp die more readily in some people than others? And she's defined a large number of genes that are different. And that was a paper that won the best paper of the year in the Journal of Endodontics a couple of years ago. Anyway, so the microbial irritants eventually overwhelm the pulp. Pulp dies, and you develop apical periodontitis. So our task clinically is very challenging because we don't really see that microbial biofilm. We see surrogates like the apical lesion. So the apical lesion is what we see on the radiograph, the demineralization that you mentioned. And then we do the treatment. We sort of think where the pulp biofilm resides, and we clean that space, and then we fill it and we seal it. But at the same time, we have no way of imaging that biofilm directly. So we don't know to what extent we are effective in removing it. We also don't know if the biofilm has overflown slightly above or beyond the apical foramen to where the pure endodontic treatment within the root canal is not sufficient. And then further treatment might be necessary, such as root end surgery. So the lack of imaging and the use of the periapical lesion is itself, kind of a way of knowing about this disease indirectly rather than targeting it directly. And when we talk about periapical lesions, the periapical lesion is actually very helpful. It prevents two sequelae from happening that are devastating for the patient. The first is spreading infections that could kill the patients. It can be a spreading infection, it can be severe, and it can disseminate bacteria throughout the body, and it can be horrendous. And the second one, of course, is osteomyelitis, which is rare to happen in the oral cavity. But the periapical lesion provides an opportunity for the bone to reseed and the immune response to step in and surround that biofilm. And for the most part, it's asymptomatic, meaning that it is successful in controlling that influx for the most part. And so our task is to essentially find what's causing it and treat that. You mentioned the radiographic changes. Yes, well, we have found out that the periapical radiograph is not necessarily that sensitive in detecting it all the time. CBCTs are more sensitive. But the question is, do we have to do that for every patient? Do we have to follow with post-treatment evaluation at that level, or should the periapical radiograph be sufficient? That is a question that we continue to grapple with as a specialty, especially that we need to define standards not just for the specialist, but for all practitioners, whether or not they have CBCTs.
It's interesting. Dr. Fouad, it's funny. You started the episode talking about how we're defining our outcomes related to our treatments. And one of the things that you always talk about, Dr. Nasseh, is this, the concept of the same topic, which is like, are we looking just at our x-rays to evaluate our work? Are we looking at the patient to develop a real, basically barometer for how the treatment success was? And, not to necessarily switch gears, Dr. Fouad, but it got me thinking sort of about your work, and Dr. Nasseh alluded to it in with diabetes and this concept of how there's impaired microcirculation, there can be persistent infection, you have impaired neutrophil function, all these things associated with diabetic patients. And frankly, I feel like so many of my patients, or a large percentage of my patients, oftentimes come with this prelude or this background of diabetes, and it's not something so rare that we don't encounter on a daily basis. But we'd love to hear your thoughts a little bit more in depth about what the effects really are on a day-to-day and practical basis, coupled with your research relating diabetes and, of course, endodontic outcomes.
Very well. So my passion for the study of diabetes in endodontic patients started when I was at the University of Connecticut. I worked there for many years. And during that time, I developed an electronic health record for endodontics that included the patient's medical history and the periodontal probing and attachment loss for the teeth that were endodontically treated. We also added the radiographs and so on. That was in the 1990s. So 1994 is when we had this up and running multi-platform secure client-server database that allowed us to capture all of the cases that all residents and all students and my faculty practice were all inputted in that. So we developed a database of thousands of patients. And then I started to do queries, because once you have the data, you can easily query it and find things that you cannot find when you're treating patient by patient every day. And the finding was that patients with preoperative apical periodontitis, periapical lesions with pulp necrosis or persistent disease were healing less in diabetics compared to non-diabetics. Now, this was mostly in the 90s and through 2001, back when the drug metformin was relatively new and not most patients were not on metformin at that time. And so we published this data, and it was longitudinal, and we followed all these patients. These were all our patients, and we only looked at those that we had follow-up for 2 years or longer, just to make sure that we are capturing what truly is persistent disease rather than just healing disease. Subsequent to that, a lot of people around the world were very interested in diabetes and what factors. So what we now know is that diabetes tends to be associated with poorer endodontic diagnosis. So basically more pulp necrosis, more apical periodontitis. Periapical lesions are much more prevalent in diabetics. What we've also learned is that among the diabetics, there is a spectrum, a wide spectrum of disease presentation depending on the glycemic level. So the glycemia plays an important role. And we actually published a big study from Carolina Data Warehouse. And I'm going to actually talk about that at the European meeting next month. But the issue with large warehouses, it allows you to see patterns and control for confounding variables, many medical confounding variables. And from that database, we were able to show that glycemia plays a critical role regardless of about 15 or 17 other medical diagnoses and variables, and even periodontal disease, in whether the patients were diagnosed with apical periodontitis or not. So the issues with diabetes relate to several factors. So you mentioned the vascularity, the interaction of receptors for advanced glycation end products. These are basically glycated proteins, and they interact with receptors for them, and that results in an inflammatory response. So more cytokines, more inflammation, which in our disease process results in more disease. And of course, as I mentioned, the pulp has poor vascularity to start with, so more inflammation is not good for the pulp. So it tends to die more often. But we also have hypothesized and got funded by NIH to study the microbial presence in diabetics versus non-diabetics, and we published some work on that to show that diabetics favor some more virulent organisms than the non-diabetics, and so that might be another variable as well. I mentioned the metformin question because when we study diabetics, and especially today, they are on so many medications, especially with the new GLP-1 drugs, but metformin in particular happen to be anti-inflammatory and antimicrobial. And so it lowers the effect of diabetes, and we've shown that in the large data warehouse that we've shown. Another drug that does that are statins. Many of the patients who have diabetes have cardiovascular disease and have atherosclerosis and have increased cholesterol, so they are on statins. And we've shown that just the fact of being on statins long-term shows a better healing after endodontic treatment compared to not being on statin. So much so that periapical lesions had a healing percentage about 93%, which is in the range of a vital pulp case. Mm-hmm. And so, the fact that this medical condition and the degree to which the medical condition is controlled makes an effect is something that we need to be more aware of. in endodontics.
It's interesting, Dr. Fouad, mentioning the thing with the statins and their potential on, osteoblasts and formation of lots of, osteoblastic activity. One of the conversations we had at the school was if there would be a way that we could, after a crown prep, for example, place a certain set of medication on dental tubules that could actually cause, intentional calcification. And the thing that came to my mind was that it's potentially, statins would be a good, product for that. So like a statin varnish, what do you think about that as an idea that you would put on a tooth after a crown that could then actually induce dentinogenesis and could create a natural coronal calcification? Because clearly, we all are pulp lovers in many ways, right?
Right.
But, if you could have a natural form of calcification coronally, that could, reseat the pulp a little bit. That could reduce the incidence of some of these issues. Why aren't we thinking on that front? Why aren't we thinking in terms of inducing calcification?
Yeah, I think that's a great idea, to think about how do we support the pulp doing its job, its primary job, which is mineralization, more actively, proactively, to defend itself better. I think of that a lot when patients come many years after trauma and they have pulp canal obliteration.
Right.
And it's in a tooth that was traumatized. And I usually tell residents and students, if just we can figure out the gene that was hyper-expressed with that trauma and can somehow induce it or promote it in a way that, with gene treatment that people do nowadays and is starting, maybe we can treat root canal, at least in vital pulps, root canal disease naturally. So have pulp canal obliteration instead of pulp canal.
I think.
Well, that's the key. All healthcare providers their main function is to put themselves out of jobs to reduce, to reduce suffering.
But back to your question is intriguing because what you're proposing is to place a medication on the tubules and allow that medication, whether it's statins or any. Use bisphosphonates maybe or something else.
Right. The controlled irritation.
Correct. So what we need to do in order for this to be successful is understand better the dynamics of permeation through dental tubules. Recall that dental tubules have dental fluid that's pushing everything out. In fact, that's one of the defense mechanisms.
Yeah.
Correct.
Flushing.
And that outward push of dental fluid will kind of work against you. So what people have done in order to counter this, and this is now very old, is you apply an electric current. So ionophoresis, if you remember older literature.
Yes.
And that, of course, is used nowadays a lot with patches and other types of medications that people are permeating through skin.
Yeah.
Correct. And so if we were to allow a drug like that a period of time to permeate through the dentin, then maybe it can have a biological effect on the dental pulp. So what we need to do in that respect is have a model that you can try it on, and then you can do clinical trials after that if the model is successful. Because we need to know and understand things like how far we are from the pulp, which is very difficult to determine clinically, and also the degree, the dose response. So the degree that you want to have the medication get into the pulp, the kinetics, basically.
Yeah, just activating the odontoblasts without actually creating irreversible harm, essentially.
Correct. And the other thing is you can use the same strategy probably in a simpler manner to in vital pulp therapy. So rather than just use MTA on the pulp directly, before that, we can treat the pulp, to reduce the inflammation, so put some anti-inflammatory, and then allow some medication to induce the stem cells now to provide the dentin bridge and so on. So these are all things that people have been very interested in, but we haven't made a lot of progress as far as I know.
I mean, we've used calcium hydroxide. Obviously, that's the essence of what we've been getting, the dental bridging, and that's been the concept of doing some type of a vital pulp therapy. But it feels to me like having something that would be, because I mean, you obviously can't put calcium hydroxide everywhere under the pulp, because then that's going to have a restorative issue with whatever is going to come on top of it is not going to bond. But if there was a way, as you said, whether through electrophoresis or something, to push something through the dental tubules,
Yep.
and then be able to seal the top of it after that, that could potentially be an interesting model to create.
Right, and I think that tricalcium silicates really work through the production of calcium hydroxide, and that's how they keep the pH very high, and they induce mineralization that way, and that has been shown. And they are also very stable. Once they're set, they are not washed away as calcium hydroxide would. But the question is, how can you then predict that the inflammation that is there is not going to continue at deeper levels of the pulp and cause demise of that pulp? So how can you treat the pulp before you apply the MTA? Treat it medically, in other words, place anti-inflammatories or active osteo or dentin induction, dentinogenesis.
If you could selectively actually stimulate the odontoblasts without stimulating osteoblasts, so odontoblast specific target, you could take systemic medication to cause induced generalized calcification. As you see with some patients that are like, on dialysis or any of these patients, you can have total calcification, and that could certainly be a potential solution as well.
When you think about the best, when you're working through a calcified case or calcified canal, sometimes your mind wanders to what if there was a natural process where you could induce this, like you guys are talking about. I wonder if Dr. Fouad, through all of your research, you've ever looked at anything. Obviously you were a part of the team and one of the leaders of the 2020 International Association of Dental Traumatology guidelines. Since then, if anything has evolved or changed dramatically, relating to leaving a tooth alone in terms of endodontic treatment that's been calcified through trauma because of the natural
calcification, dystrophic calcification.
The natural calcifications that are occurring as a barricade almost. Has anything really changed since the guidelines have been published?
Yeah. Interestingly, we met the group for this trauma guidelines met a few weeks ago to consider that very question, whether there have been enough changes to warrant an update for the guidelines. So the area that you specifically asked about with respect to pulp canal obliteration, I'm not aware of changes, but I'm going to share with you an idea that is really intriguing, and we haven't really studied it enough. So we've known since the 1960s that pulp canal obliteration is a process that indicates the pulp is active, it's vital, it's doing its job, it's just on hyperdrive doing it. And so, people used to do interceptive endodontics to try and prevent that because they thought it would be very difficult to find that pulp space if it gets calcified, but they stopped doing that because the rate at which the pulp dies is very low. And so many times, though, you see those cases 20, 30, 40 years after the fact, and the pulp is almost completely calcified. But now the residual pulp has died, and there's a periapical lesion, and sometimes it's also painful. I have done surgeries on some of those because there is no canal space that you can find, or use guided endodontics to find a canal that's receding in the apical area. So now the question is, why does the pulp die after doing all this work for so many years and cause a disease process? I mean, it's been successful for years and years, and it's now far away from any coronal source of irritation.
I've always had that question. I can't wait for that answer.
And, right. So we don't know the answer to that question, but the issue here is we can speculate that maybe the vascularity is now so low that it's not conducive to keeping that tissue alive anymore.
It's
and
the
when
old
tissues
strangulation
die,
theory coming back.
well, not the strangulation necessarily, but issues of perfusion, just
Right.
pure, inability to have enough vascularity. Like it happens in any older tissue, sometimes you have vascularity issues, and for that reason, the bacteria will find that space that is.
So that's actually a
smaller.
good question, Dr. Fouad. Where would the source of bacteria be in that situation?
Yeah.
Is it
So
intravenous or is it local?
the bacteria are circulating around the pulp in all the vessels around in the periodontal ligament, in the gingival tissues, and so on, as any other tissue, including the brain, including any tissue. There was an elegant study that was published in the Journal of Endodontics, and that one also won an award, where they sampled the normal pulp in teeth that were going to be extracted for orthodontic reasons. These were normal, natural teeth in children, and they isolated them, sealed around the rubber dam, disinfected everything, took all kinds of samples to make sure that they're only sampling inside the pulp. And they found bacteria with very sensitive molecular techniques in that pulp. So where are those bacteria coming from? Well, that's normal circulation. Like if you take a blood sample from us and you look for bacteria, you will find some circulating, but that is not a clinical problem, because the bacteria being in the blood, that's the worst place they want to be. They've got so many inflammatory cells there and macrophages that they will eliminate them. But once the pulp starts to degenerate and you have no viable circulation anymore and no host response, then the bacteria start to form a biofilm. And in that case, they start to form disease. And so what is the source? The source is just normal bacteria that we have in us and on us all the time. But as long as the pulp is vital and has adequate circulation, those bacteria are of no clinical significance. But once it is devitalized or degenerating, then the bacteria start to grow and cause disease.
So would those bacteria, therefore, if they were to be taken out and just do some DNA, checkboard hybridization to see exactly what they are, would they be non-odontogenic bacteria for the most part? They would have sources that could be from the epidermis or
correct.
From
and if you look at the data in that particular study, they didn't have a lot of patients. They had only about 10 patients. Most of these organisms would be common food bacteria, gut bacteria, other bacteria in the mouth. Streptococci, of course, are common, and they are just residing in a commensal type of role until they find an area that promotes their growth into a biofilm that then becomes pathogenic.
So would you then say, based on this evidence that you're putting forth, that the idea that we thought was defeated, which was anachoresis, is back on the table?
It's not really anachoresis in the sense that they're coming from faraway organs. The most likely source of these bacteria are just the circulation around that area, which is the gingival sulcus and the oral cavity, because that's sort of the closest one that keeps feeding bacteria into that local circulation all the time. And so we find lots of endodontic bacteria are, even in traumatized cases that have not been exposed and have not been fractured, are very similar to gingival microflora as well. But, if you look at that one study with the normal pulp, you'll find signatures of other types of bacteria also, mostly from the oral cavity through food and things like that.
Very interesting. Annie, you want to...
No, I'm just listening to this. I was interested when we talked about the anachoresis, because I'm trying to figure out where does the anachoresis come in, but the local circulation makes so much more sense to me.
But to be honest with you, the local circulation to me, because, if you think about it, that's, unless we're talking about the lymphatic system getting mixed up with it, if it's venules, they're going to drain away. They're not going to mix up with the arterial blood. So if it's picking up venules, it's just going to have to make a full circulation back to the heart and back. It won't be a local phenomenon. You can't have that anatomically. That wouldn't, right? You're not going to have mixture of the venular blood with the arterial blood that would then end up in that area. So, I mean, that is interesting to me.
So the evidence for that comes from data that really sampled both of those sources in the same patient. So Dr. Brenda Gomes from Brazil is one of the most notable endodontic microbiologists in the world.
We had her at the school several months ago,
yes,
talking about the same thing. Yeah, she's great.
Yeah, I think she went to Boston about 10 years ago on a sabbatical and worked with Bruce Pastor at the Foresight.
Oh, yeah.
And I know Bruce very well. We've worked together on previous studies. But in that study, she took samples from patients who had both endodontic infections and periodontal disease from the same patient. And they published the sequence studies, and you could see very elegantly the overlap of bacteria in both environments from those patients, indicating that the gingival microflora is a very, very important source of bacteria for endodontic infections.
Yeah.
Again, in the normal pulp, those don't affect the pulp because the pulp has vascularity and it really is very formidable. And as long as the pulp responds, we don't have to do anything, regardless of how significant periodontal disease is. But if, however, the pulp is irritated, degenerates in some fashion, those bacteria quickly rush to that area and have access to that. And also have an environment that is conducive to their growth in that area.
But I mean, to me, that sounds, as opposed to it be through through the systemic vasculature system, it makes more sense for it to be a direct invasion through clavicular fluid up through the cavity or whichever means of infection. There is even dental tubules, direct as opposed to. So, but those are good points. Where do you think right now is the biggest misconception about endodontics in the eyes of restorative dentists or the general public, not people that are speaking at this level of, the molecular basis of what's happening with endo and all the cellular basis, but the average general dentist, what is it that they really should know about endodontics that they don't know about their disease model or their model of the procedure?
Very well. So it follows from the discussion that we've had that the use of the aseptic technique in endodontics is very important. And starting from the use of the rubber dam, disinfection, hypochlorite, instrumentation, sealing the root canal environment very well, prompt restoration of the tooth, adequate temporaries when temporaries are placed that are sealing and bonding to the tooth rather than just cavit that flows out of the tooth and it doesn't really seal that well. And so that is a very important concept. The other thing general dentists should be aware of is the importance of diagnosis. So when we talk about, for instance, vital pulp therapy, one of the critical things in vital pulp therapy is knowing how to diagnose the condition of the pulp, using pulp testers, listening carefully to what the patient is saying about their symptoms. And I'm glad that the AAE is collaborating with the ESC on generating a new terminology that we're just seeing the beginning of their discussions now to move us away from the terms reversible and irreversible to something that is much more biologically acceptable and allows us to understand the spectrum of pulpal health and treat it accordingly. General dentists should also be aware of the complexity of root canal anatomy. All teeth other than maxillary anterior teeth have a significant chance of having additional canals in the buccal lingual dimension. And they happen to be in that buccal lingual dimension, so it means that we need shift radiographs in order for you to be able to see if there are additional canals in the tooth, because additional untreated canals are a big source of failures of endodontic treatment. Knowing the basic principles of endodontics, as we just discussed, is very important. And then also understanding the levels of complexity, when it is an adequate stage to refer a case. So the AAE case complexity system that we mentioned has an electronic version where you can put some of the variables, answer some questions, and it triggers for you the level of complexity. And we've actually sent messages to our local dentists here and promoted that and sent them the website for it because it's really neat to be able to do that. The other thing that I would just talk with general dentists about is the indiscriminate use of antibiotics. People use antibiotics extensively. And many times they will use antibiotics instead of analgesics because we are now moving away from opioids. And so they want to prescribe something for that material, that medicament to be quote unquote effective. So they go to a prescription of antibiotics for pain. And unfortunately, that has led to dentists becoming among the specialists that prescribe a lot of unnecessary antibiotics. And of course, we have a big problem with antibiotic resistance organisms in the community. There were guidelines last year from the ADA on the analgesics and pain medications. And now those guidelines have become on the website, in the ADA website. That's a new program the ADA is putting together called the Living Guidelines. In other words, the guidelines are now promoted on the website, not as the original article that was published in JADA, but as a series of links and questions that you can just answer your question, and then it will refer you back to where the data is if you want it, and you can drill down to the articles and so on. But it's an online menu-based interface, user-friendly interface for that. And so it basically will tell you about the power of NSAIDs for managing endodontic pain. And of course, we published the guidelines for antibiotics a few years ago that these are only necessary for cases with spreading infections. The other thing I would just say that we are in an age where we are looking at outcomes of vital pulp therapy. This is something that is very powerful and very new, provided that we have adequate diagnosis of the conditions and recognize the difference between deep caries and extremely deep caries. And it sounds the same. Mm-hmm. But we have negotiated this back and forth between the European group and the American group, and we've debated on AAE meeting panels. But we've realized that when the caries is into the pulp, there is no separation. That pulp has a significant amount of coronal inflammation, regardless of symptoms. And so those cases really would benefit from a complete pulpotomy. That's not a pulp capping, and it's not a selective caries removal case. And randomized clinical trials have shown very clearly that a complete pulpotomy is significantly better than selective caries removal in these cases. And so recognizing all of these variables is very important for us to promote to general dentists.
Do you know of any technology, whether it be ultrasound, maybe it even be thermal, of evaluating the coronal pulp in a non-invasive manner? Because I'm looking at from not just the academic viewpoint, even from the product viewpoint, that changes the game dramatically. But it's an interesting thing because to me, the one thing that would kind of, again, looking down from 20,000 feet, I think it may possibly something that may be thermal related rather than something ultrasonic in nature.
So you're asking about a chairside method to diagnose the exact condition of the dental pulp.
Exactly.
Yes. And believe it or not, I've been submitting an NIH grant on that very topic for several years now. Yeah. And it actually almost got funded with a prior program officer. Unfortunately, she left the institute, and the new one.
No luck right now.
When we started from
She's an
zero.
implantologist now.
No, she left the institute altogether. Yeah, but anyway, so the idea there was to, there is a lot of inflammation in the pulp. There are so many mediators that are expressed. You don't know which ones are important. More importantly, you don't know which ones of them are predictive that the pulp will be necrotic, that it will not survive, that it will truly die, regardless of what you do. And so what we proposed is a very simple protein analysis using a large number of proteins, using a relatively novel technology that takes a tiny little sample of blood and it analyzes it for a large number of proteins. And the intent was to figure out the one or several proteins that will predict that the pulp will die anyway, regardless of what we do.
You didn't get this idea from Theranos, did you? I'm just joking.
Yeah. So and actually the people were very supportive, and we published a couple of papers. In fact, I collaborated with Dr. Saberi at UCSF, and we published one paper, and the other paper will be published in IHA in a couple of months. But what I wanted to tell you is the ability to predict the status of the pulp relates to what's happening biologically in that pulp at a molecular level. One of the critiques, believe it or not, people said, why don't you study the microorganisms? Because those may also be predictive. And of course, whoever writes that is probably not aware of the fact that this is a situation where you have a vital tissue. You've removed all the caries. You've disinfected with hypochlorite directly on that pulp. So all that you're left with from microbiota are planktonic. And the host response can deal with planktonic bacteria relatively well. And so studying the microflora at that point is probably not as important as studying what the host is doing and whether it's going to survive or not. But in any case, I think that probably is the, once we get, and the reason we need NIH for that is because the sample size that is needed is so large. And in order for us to do a true randomized clinical trial and compare that to a gold standard, such as root canal treatment, to look at the efficacy of the treatment, you need a large sample size, and you need to cover the treatment for patients, which means a lot of money involved in doing this. But anyway, so our application, actually, the last iteration is still being considered, and hopefully we'll hear about it soon. But I want to just go back to your question that maybe there is something we can measure, and it may be something else other than proteins, such as you mentioned, the thermal change or some other viable metric. The important thing that the AAE position statement emphasized 2021 was that you visualize that the tissue is vital, that it's bleeding, that you can stop the bleeding in a relatively short amount of time, and that you're dealing with basically a connective tissue that you can then put a material like MTA over it. And the other thing that I think will be important in the future is to add some anti-inflammatory before you apply the tricalcium silicase, that you can enhance the host response, and maybe also finally add EDTA, because that will bring in some of the growth factors from the dentin that allows the mineralization to be more effective.
So, Dr. Fouad, you mentioned taking a blood sample and checking for the growth factors. Wouldn't it be, in cases, because if you're already in there and getting the blood sample, it's already a little bit too late. Wouldn't it be a more interesting thing to be able to do it for indirect kind of pulp caps or deep cavities and just literally just looking at the interstitial fluid by just waiting in to get a little bit of dentinal sweating and then pick up some of that and see if you have any specific growth factor related based on predictive pulpitis afterwards, right? That could be a more general dentist kind of applicable thing.
Yes. So my very good friend, Dr. Cindy Rauschenberger, when she was back in the early 90s, she was at Northwestern University finishing up her program, and with Dr. Ed Osetek.
Of course. Yeah.
And they looked at some of these factors. And then she went to Maryland. And when she was at Maryland, she sampled dentinal fluid, as you've described, looking for mediators like IL-2, for instance, interleukin-2, and other cytokines. And then she went to private practice, and that work stopped. More recently, Matthias Zinder from Switzerland picked that up, and he started looking at matrix metalloproteinases, which are enzymes that degrade the tissue. And he reasoned, and that was appropriate, that whenever you have these enzymes, you're looking at the demise of the tissue. The tissue is dying. You're just trying to look at it early. And he did the same thing through the dentinal fluid. And then more recently in Chile, people have looked at that as well to sample. Now, the problem with that type of assay, and all of these authors have acknowledged, is that the amount is too small and you don't have gold standards. Like, what would be an appropriate amount that would tell you above this is associated with disease and below this, the pulp will do fine. Moreover, there is no clinically acceptable way of measuring the remaining dentin. So you cannot know how far you are from the pulp. I remember Charlie Cox many years ago tried to use apex locators for that. He tried to use the resistance of the dentin to measure that, but he was not successful. But that's another challenge, is that if you're dealing with 1 millimeter is different from half a millimeter, or 2 millimeters. So it's hard to determine the amounts of these mediators before you actually expose the pulp.
For a tissue sample, I can totally agree, because otherwise it wouldn't really matter. As long as you have the interstitial fluid from the dental tubules, then the question is to run a trial and compare outcomes following the filling after caries removal in terms of sensitivity to the percentage of, I don't know, MMP8, so, or some other MMP in there to see if they correlate, and ends up being some type of
and that's what Matthias wanted to do, essentially. He wanted to just have a chairside tool for dentists to use. The other thing that is even easier to do is to measure crevicular fluid. So people have done that. And that correlates, believe it or not, with pulpal inflammation. And the only problem with that is if the patient has gingivitis or periodontitis, then doesn't work, because
But it's so funny, because we've done that, and actually the Gibbs at our school has been working on this area as well. And whether the mechanism is hyperalgesia associated with inflammation at the apex of that tooth, or if it's actually directly through the PDL to the clavicular fluid, I personally had noticed through just years of experience, having done, thousands and thousands of root canals, that when I was because I always probe every tooth during diagnosis before I do the pulpal testing. And I've invariably found that patients are a little bit more sensitive to the probing around the tooth that has apical periodontitis.
Right.
Yes, that is true.
And that is clearly then can be found with these, exogenous factors.
And it makes sense, because, the apical periodontitis, particularly symptomatic apical periodontitis, the whole periodontal ligament is affected by what's happening at the apical periodontal ligament. Yeah, that makes perfect sense. The question, though, is how to rule out, and what people have done for that, by the way, is compare that clavicular fluid to the contralateral clavicular fluid. So you take it from the other side and you compare the two to get a gauge, assuming that the gingival disease will be similar on both sides of the mouth. So again, these are all good ideas, but we don't have any usable chairside test yet.
Dr. Fouad, it's we've touched on a few different things here. We talked about a lot about pulp biology, the systemic endodontic connections, trauma. But I think particularly the audience, and you're talking to a group of people who are very interested on the innovation side and how this can translate from research, chairside, all of the above, to the the markets and how people can use it on a daily basis. So two parts to this question, and I think it's important for us to separate the wheat from the chaff. What area specifically within endodontics are you most excited and passionate about research-wise? What do you think will be the most important thing to focus on in the next 2, 3, 5 years, financially, time, energy? And also, what do you think is the most overrated or overhyped topic of research within endodontics? And that's a more important question.
Without
creating a little bit of controversy here, huh?
We got to know the reality here.
So, Dr. Fouad thinks, who are you going to throw under the bus, Dr. Fouad?
No. Just topics here.
Very well. Yeah. All right. So very, very important question, and thank you for that question. So there's no doubt that CBCT has been a technology that has been really very remarkable in what it has shown us, how much it has allowed us to understand root canal anatomy and to treat the patient well, particularly when the initial treatment fails or patient has persistent disease. I think that in the future, if the exposure, radiographic exposure, the ionizing radiation exposure is reduced, and the footprint of the CBCT unit is decreased to where CBCT can become chairside, I think that this will be similar to what we experienced back in the 1990s with digital radiography, where people were resistant to digital radiography until it became, the one thing that everybody swears by, and nobody, or very, very few people, use film. But the other thing that is really exciting around the corner is dental MRI. So at the University of Minnesota, they are now using a dental MRI from Siemens that is compelling. And the reason it's compelling is because, of course, it's much less time than the medical MRI, so something that is usable, but also that it has no ionizing radiation. So it does not expose the patient to ionizing radiation and whatever. The problems with that is most of it we don't really understand fully at this stage. I think that static and dynamic navigations are compelling and interesting. And as I mentioned before, the technology needs to be simplified and streamlined. But robotics are very exciting. And the fact that a robot can perform root end surgery, which was published last year, is interesting. And what I mean by that is now we have, like we experienced in the early 1990s with the introduction of nickel titanium instruments, and many general dentists learned how to use them, and endodontics now became very popular because it was not as difficult for general dentists to prepare canals as it used to be with just using hand files. And so using robotics in the future to help us with some of the procedures that may be a little more challenging, aiming it directly at the root canal orifice with your access preps, so that, the access prep many times, particularly for calcified cases, takes a long time, and it allows you to find the canals. If you can aim directly at those and basically go directly to the canal using a very standardized access, that would become very, very interesting.
I have a comment I'd like to just interject here.
Go ahead. Yeah.
Back in 1993, I had done pros principally in the service for 14 years. And I went back to endodontic training at Penn, and I was obviously the oldest resident in the school at the time. I was like 41. So when I finished my program, I came back up to Massachusetts to reactivate my Massachusetts license. And the person who was head of the board was a very famous gentleman and a wonderful man, Walter Goralnik. I don't know if you ever heard of him. He was an oral surgeon. He was really the gentleman to really push, the DMD, MD program. So Walter was a surgeon, and I came in. And one of the things I had done as a resident at Penn, I had created a newsletter called The File and Reamer. And I did all the photography. I wrote all the articles. And then Bill Broomfield down at LD Koch in Milford, Delaware, they were very kind to publish it, right? So the school was very happy. Everybody was very happy. I sent it to both Penn alumni and Penn undergraduate alumni who maybe did endo at some other school. So when I went up to reactivate my license, I took a whole issue that was on the introduction of microsurgery. Because at that time, Dr. Kim had just came down to Penn, and we were like light years ahead of everybody else. So I'm sitting with Walter, with the only two people in this room with a big round table, and I'm so excited, and I'm showing him this issue of the File and Reamer dedicated to microsurgery. He looks at it, and he throws it across the table, and he goes, "What the hell do we need a microscope to do apical surgery?" And obviously, he got into the whole riff about, holes, drills, and everything else. But the one thing is he finished, and because he was a wonderful man. He said, "Listen, here's the point." He said, "How about the cost of care? Are we elevating the cost of care? Are we decreasing the access to care?" He said, "Having said that, welcome back to Massachusetts." So I've got to know Walter very well through the years at Harvard. But the one thing that keeps circulating in my back of my head is where's that balance between technological advances, and outpricing the procedure for the majority of patients?
Very well. So that's actually my next point that I was going to mention. The technology is nice and it allows us to treat difficult cases. And that's probably what we've done the best in the last 50 years or so. I don't think we've really improved the outcomes that well if you look at the changes among the studies. But we've certainly treated many more difficult cases, and we've done them up to the standards that we all know and have been applying. But my next point is to discover that magic material that is a very powerful antimicrobial and at the same time biocompatible. If we can figure out a material that allows us to target biofilms and inactivate them and reduce their pathogenicity. And at the same time, we can perfuse that or push that into the apical area and try and have an environment that is conducive to tissue regeneration and not microbial growth. I think we will have achieved, and that may be an expensive material, and it may not be. I don't know. I think antibiotics were interesting for a while, but the problem with antibiotics is resistance. And of course, I promote topical use of antibiotic more than systemic for that resistance purpose. But at the same time, we need to figure out something that does not promote resistance, something that is perhaps a universally antimicrobial. I think that the issue of promoting vital pulp therapy addresses what you're talking about also, because vital pulp therapy is not expensive, and it has the potential to be adequately done by general dentists without the endodontist needing to intervene in every case, provided that they do it correctly and provided that they are able to diagnose the pulp condition well.
And but having lived in Asia for 10 years, having a vital pulp reproducible technique, it's a public health issue to me.
Yes, exactly. Yep. So, I mean, if you look at the May issue of the Journal of Endodontics, and speaking of Asia, elegant case report published on doing an intentional replantation on a case that had a dense invaginatus on the lower premolar, very, very complex anatomy. But they did an intentional replantation, and at the same time, for the same patient, they did 2 transplants with guided placement, third molars going into first molars positions. All the teeth were, the transplanted teeth were immature, and so they did no endodontic treatment. They just let them develop, and they showed the 2-year outcome with nice healing.
Yeah.
So this is, here is where people using very few resources can really do elegant dentistry that is biologically compatible and serves the patient very well, and it's really not expensive. And so I think it's not just spending too much money to get very fancy technology. The technology will have its place, and it will help us in many respects. But we also need to develop the biological aspects of our specialty and figure out how to effectively treat our patients this way.
That's exactly true, Dr. Fouad. And that's actually what I tell the residents all the time. It's just, following principles rather than rules in many ways. It allows you to kind of think outside the box and not always think that the solution is one big, expensive, shiny toy, but rather using the principles and the scientific round of things that you've learned to good use and be able to be creative in coming up with simpler solutions for your patients. So if you were then, in that case, tell me what are, as a final question, I think here, would be the barrier for increasing the success rate by an endodontist? Because you mentioned something that has been really in the back of my mind, is that all of these technological tools that we've used and we've had and we've developed, and we have helped develop some of these over the past few decades, has really helped improve the efficiency of the work, increase the simplicity and the efficiency. But we're still lacking that last 5% of cases. And you mentioned that, it could be a chemical that could then kill the biofilm because that's the barrier, right? So what else do you think can be done? And how can we get to that point where that last 5%, besides some of the biomechanical issues, which are stuff that we can't do anything about. If a tooth is just broken down, it may crack and break. But in basic cases in which you could reach the end of the root, there is a lesion, but it doesn't heal, how can that be improved?
So to answer this question, I'm going to push back a little bit on the 5%. And the reason I'm going to do that is because most of our studies, no matter where they were done and what technology they looked at for looking at outcomes, have shown that in cases with preoperative apical periodontitis, the outcomes are probably in the 80 to 85% success. In recent years, we've noticed that people are starting to use terms like stringent criteria and loose criteria for measuring outcomes. In fact, we just reviewed a paper from that May issue of the Journal of Endodontics, where people were doing a randomized clinical trial on single cone with tricalcium silicate sealer versus vertical compaction with AH+. So a randomized clinical trial, and it was done, in a number of cases, and then they used the loose criteria and the stringent criteria. But what I noticed the most from this study is that at 5 years, and this was 5-year outcome, amazing, it's really very good in the length of time, is that their success in both groups was about 75%. And so you've got 25% of those cases with the stringent criteria that did not heal completely. With the loose criteria, that got it up to about 82 or 83%. So we have a number of cases. If you just bring back most of the treatment done, not just the ones that are willing to come back, because our patients just don't come back for follow-up when they're comfortable, or if they develop a problem, they go to the oral surgeon or the dentist and have it extracted, and the endodontist would not know about it. And so the issue here is to try and maximize our outcomes across the board. And, for people who say, well, we're not studying them long enough, I will say, we're waiting, 2 years, 3 years, 4 years. Why should we wait that long? Why can't we find out complete healing within 6 months? If you extract the tooth, that socket will heal within 3 months to 6 months. In fact, they will place an implant in that socket within that length of time. In other words, there is something that remains that makes that healing a little slower. And we need to speed this up. This is what we found with the statins. The statins, amazingly, brought the apical periodontitis to the same level as the vital pulp cases. And so for that reason, I think it is important for us to find ways to enhance our outcomes to where we have complete healing in endodontics following endodontic treatment more effectively and rapidly, so that we can define that within 3 months or 6 months, we can determine the need for a retreatment or a surgery or something else. Because if you wait a longer period of time, there is less chance that that patient will come back to the practice for follow-up, particularly if they're not in pain.
Right.
And so I think with respect to your question about the barriers, I think we need to pay more attention to the patient's medical history. I saw that very clearly when I went to the University of North Carolina, worked there for a while, and then we implemented EPIC, which is a medical system that has a dental module. And I used EPIC for my patients for a year. And the one thing that I noticed is that for many of my patients, older people, usually patients who've had a lot of dentistry in their mouth and so on, and really want to save their teeth in Chapel Hill, North Carolina, those patients had very complex medical histories. Many times they forgot pieces of it. Many times they were not on some medications that they were supposed to be on, but they were not on them. And my ability to have that understanding of their medical history that is written by the physicians allowed me to have a better concept of their medical and the complexity of the medical history. And it also allowed me to question my own findings from previous data, where all we do is ask the patient. Because, for instance, you mentioned diabetes. We know that about a third of the patients who are diabetic don't know it. They are diabetic, but they're not symptomatic, and so they have not been tested, and so they don't know that they are diabetic. And this is from the medical literature, from surveys of patients that essentially were screened. So I want to tell you that I think this aspect of understanding the medical history and its influence on outcomes is something that we are just beginning to understand this, and also the role of all the medications, including the plethora of biologicals that patients are taking nowadays for a variety of conditions. I gave a talk about that at the AAE meeting, and there are so many of these, and they target some of the molecules that are important for pulpal and apical inflammation. So having better antimicrobials, having better understanding of the patient, perhaps a better imaging in the sense of MRIs and other types of tools that allow us to image your patient better may allow us to enhance our outcomes in the future. And developing that magic antimicrobial that's also biocompatible.
We all need that.
We're all trying to do that.
Can't come fast enough. But Dr. Fouad, I mean, I want to add one little item because I think this is an important thing in terms of since you mentioned that some of these studies are showing a lower success rate based on cases with lesions. I think it's also another factor that is oftentimes not expressed in the literature. Many of these, including the Toronto study that everybody talks about and kind of quotes, a lot of these cases are done in schools by students. And one of the things that we know for sure, and I know now myself after having now completed over 28,000, nearly 29,000 cases, is that there was a very big difference in the early part of one's career and later on as you get more experience, right? This is a skill-based procedure. And that many studies have shown the difference in the success rate considering the skill level, right? So I think the best way would be to find, if we want to find out what is the success rate of the procedure, we want to find out what is the success rate of the procedure, not what's the success rate of a group of students trying to do endo. So we need to find really experienced, highly experienced practitioners that are just clinicians, and then do a study to find out what this is. Because, I mean, to be honest with you, 75% success rate on these cases, if many of the clinicians that are out there, if they have a 75% success rate, that's not going to work out in clinical practice.
Very well. So I will tell you that all of these patients, 100%, were asymptomatic. There were no symptomatic patients among those in that study that I just referenced. But there are many other studies like that where most of these are healing. The lesions are a little smaller. That's why the difference between the loose criteria and the stringent criteria and so on. But back to your point that you made, which is very, very important. Yeah. And when I talk about gentle wave, for instance, and I mentioned the studies that were done and the fact that most of these practitioners are very experienced practitioners, they're very good. And I know that because at the time when people bought these equipment, they were very, very expensive. They still are. And only the people that are very successful in practice, that have been in practice for many years, are able to purchase some of these equipment. But if you take the most skilled practitioners like yourself, and you bring that group and say, well, we're going to measure the success of the procedure that has been done by those group of practitioners, that result, I'm sorry to tell you, is not generalizable because there aren't enough of you for this world. Yes. And so we have to...
it's just the common denominator is the group that we're talking about, right? So the less skilled practitioner or the general dentist. So I almost feel like the way that the data should be presented is based on the common denominator, which is the less skilled.
But so here's the thing, though. So then we have to redefine the way we actually provide the information as to what is the success rate of root canal therapy or what is the success rate of the average endodontist. There's two separate things. The success rate of root canal therapy is the success that is possible. Okay. But the success rate of the average endodontist is what is practical. So to me, what is possible is the main thing because that's the procedure.
So if you go to the general dentist's outcome, and you look at cross-sectional data, those outcomes are much lower. Think of Ray and Trope and Buckley and Spomberg and all of these studies that just look at root canal treatment and periapical lesions. About a third of these cases have lesions anyway, okay? So, and that's basically a systematic review that has shown that. But the issue with why do we rely on programs in schools and students or residents, you have to realize that when we are looking at longitudinal outcome data, we start with what is the diagnosis, so we know the history of the case, and we can now differentiate vital pulp, necrotic cases, and so on. We also are able to differentiate throughout the treatment of which cases met the standards of care and which cases did not. It may be that the specialists do some other types of manipulations of the case that allow them to be more successful. But when you've got a case where you have good isolation, good instrumentation, good working length instrumentation, and it fulfills the criteria, prompt restoration, and you're following that and you define it as such, it should not matter who did the treatment, because you have now followed the basic principles that we are trying to get everybody to do. Now, the fast practitioners will do many more of these per unit time than the average resident or the average student, of course. But at the same time, the standard should be defined so that anybody who fulfills those standards should be able to get a similar level of success. If you look at the difference between endodontists and general dentists, where you compare them side by side, the study from Alabama, as a matter of fact, Ali and Eleazar, is a good one to cite here, and that's the one where they showed the survival is higher, about 10% higher with the endodontist compared to the general dentist. But those were not randomized, so it relied on one office, and which cases were done in the office versus referred to an endodontist. And so, but there are 2 or 3 of these that show essentially the same thing. Endodontists have a little bit of a higher success, at least survival of the teeth that are endodontically treated. When it comes to the healing of apical periodontitis, even with tools like gentle wave, and you see the Sigurdsson paper on gentle wave is a good example of that. These are all experienced practitioner endodontists that had cases with apical periodontitis, and they will tell you the success was 97%. But you read through the result, the complete healing was 80% in that study. So, and what I want to say is most of these patients are asymptomatic. Don't get me wrong, but we have to understand if there is a lesion that is not healed completely, is that basically a function of a biofilm that is escaping our attention and somewhere that needs to be maybe surgerized or something along those lines.
Right. It goes back to what we discussed earlier, which is just the definition of success and how do we set that, and as a proxy of bone healing or radiolucency, as opposed to the patient criteria, which I think is the more important one as a disease model.
Yes.
But I think there's
patient criteria.
Yeah. But I mean, a lot of these studies also, they don't really. I mean, they just show endodontic cases done. Yeah. And then success and failure. The quality of endodontics is just left up to a certain set of, whether all the MB2s were found, if some were found, some were not, did they all have, so these are like the tiny things that we don't really discuss. I mean, it's one of those things. It's certainly a challenging area.
And it's a good point because, I know we're wrapping here, but Dr. Fouad, you spent a lot of time educating us and talking about that important link between the systemic and the medical history of the patient, how all of those things plays a factor. I mean, you might have a patient going to an extremely experienced clinician who might have higher socioeconomic status, less disease in their body, more of a willingness to abide by the advice of the endodontist, and that leads to better outcomes. So there's I think this net average is a good point. But
what Parsa said is actually really important, because that's true. Because in a private practice setting, you end up seeing patients that are generally healthier. And if you have somebody who's really unhealthy, what do? We send them to the school to see their residents.
But gentlemen, especially the 2 gentlemen in Boston, I'm directing this to you. The restorative aspect is also critically important.
Yeah, for sure.
Everybody gets into a carotid distension argument about this rate or that rate, but you're forgetting that who's restoring the tooth. Oh my God, there's a huge open margin. What a surprise. Okay.
Yes.
So there's a lot of different factors that we have to put into an accumulative analysis.
That's truly very important.
So, and you touched on a very important point with the patient who has a lot of disease.
Yeah.
Which, by the way, includes periodontal disease and includes many other systemic diseases. Many of these patients are prone to systemic inflammation. In other words, they have inflammation in general. They call it metabolic syndrome. And those patients tend to have also gastrointestinal problems, urogenital problems. They have a lot of other inflammation going on in their body, which sustains apical inflammation and pulpal inflammation, continuing and persisting beyond the time where most other patients who do not have that may have more rapid healing. So that goes back to what I mentioned about knowing the patient, the host, and how they respond very, very well. And the other thing is there are several studies now that have shown that even among the patients that you consider healthy, if you look at genetic variations among them, there are some gene polymorphism traits, particularly for some of the cytokines like IL-1 beta, that are associated with persistent disease compared to other patients. So when you know the history of the cases, they were all done well according to the criteria, and you study that one variable, you find a difference between those that have the allele associated with more inflammation compared to those that don't. So it's very complex, and we just need to understand. And by the way, this is not just hypothetical. They're already using that information in the diagnosis of cancer and in the treatment of cancer. So biotyping of cancer is all about figuring out the genetic polymorphism and what the patient is likely to, what degree of aggressiveness the tumor is likely to be, and how well they will respond to one treatment plan versus another. So that's already happening in areas that have heavy funding that allows them to do these studies, which has not trickled down to our area yet.
That is terrific. Well, Dr. Fouad, and Annie and Parsa, you see why I really wanted to speak to Dr. Fouad, because he really is one of the fine
terrific.
people that shows really the complexity
Yes.
of a field we're treating, and really sheds light on the reality that endodontics is not about creating, radiographic looks.
Right.
It's about treating patients in a disease process that is entirely far more complex that meets the eye. And this has really been terrific.
Wait a second, Dr. Nasseh. What did you say about radiographic look? you do live in
That's true.
Boston.
We live in Boston, so that is heresy, Annie.
The home of the look.
We have to play the game. There's no other choice. We need a good X-ray.
Gosh, I have to keep the youngins in line here occasionally.
That's right. The aesthetics of the radiograph.
That's right. It's like endodontics has become, and especially today in the age of Instagram and social media, endodontics is very susceptible to become a very much a cosmetic endodontics field as opposed to a biological endodontics.
The question is, Dr. Fouad, puff or no puff for your X-rays? What do you prefer?
Oh, that's a good question.
An aesthetic endodontist, okay.
A small puff is okay.
There you go.
Small puff. As long as you don't inhale, Parsa.
I like it. I like a small puff.
All righty.
This is
Well,
really terrific.
Dr. Fouad, thank you so much. And thank you.
Thank you as well. I
Andy,
appreciate
Parsa,
that.
and
I
everyone.
enjoyed it.
We really had a
you.
great time. Thank you so much.
Same here. Thank you very much.
Enjoy the remainder of the summer.
Thank you for joining us on the Pulp Podcast, and we'll see you in the next
you.
video.
Thank you.
Turning pulp into gold
Awesome.
with
Terrific.
every
That was fun.
All right. Very good.
word. A show
Yeah, that was
like no
terrific.
other you've
Thank you very
ever
much.
heard. Health and hearts we craft and mold. Tune into Pulp, where stories unfold.